Fine. I went to Tufts Medical School. I graduated in 1958.
And what did you do after that?
I was a intern in medicine, that is a PGY1 resident in medicine at the Yale New Haven Hospital. And then I came back to Tufts. The New England Medical Center was their major teaching hospital as a neurology resident. I then went to Columbia Presbyterian, New York Neurological Institute to do neuropathology for a year. Came back to the New England Medical Center as the chief resident in neurology, and then spent a year doing a fellowship in neurophysiology.
What was medical school like when you were there?
Okay. It was entirely another era. That was particularly the case at Tufts. They had, in general, they had professors who had been there for many, many years. Particularly in the basic science departments, they had a rather rigid way of doing things. There was a anatomy course that ran for about, I suspect 5 or 6 months, with the dissection of a cadaver, etc. The first year was anatomy, histology, biochemistry, physiology. Second year, pathology, bacteriology, pharmacology, parasitology. I don't know that anybody, microbiology, I don't know that anybody has courses in parasitology today, but we did. The chairman of pathology had been appointed, I believe, in 1926, and he lasted until at least 1969. It was a small school with a small basic science faculty, a somewhat limited student body, perhaps 115 students in the entering class, of whom 4 were women. The school at that time took students who either had gone to college in New England or were from New England. For a class of 115 students, they had about 600 applicants. It was not a national university as it is today.
What led you to choose medicine as a career?
Well, I was interested in science. I'd gone to Yale as an undergraduate. I was an intensive major in psychology. And I don't know, the idea of seeing how the mind worked, seeing how the nervous system worked appealed to me. I was going to go into psychiatry initially when I was in college. I had worked as an undergraduate research assistant on a project that related to cross-cultural studies of child training and personality development for several professors, both of whom had been psychoanalyzed and who had a psychoanalytic approach. But in my last year at Yale, I had a seminar with a man by the name of Frank Beach, who was teaching psychobiology. Frank Beach actually was teaching neurosciences, but they hadn't coined the name yet. And what he was talking about was the biological approach to understanding behavior. And I came to medical school and was interested in pursuing some projects in the area of psychiatric research. I'd done an undergraduate research thesis on the topic of how anxiety and stress influenced rigidity of problem solving in testing situations. And I was interested in carrying out some additional projects, and I went to the chairman of the, he wasn't the chairman at the, well, I went to the chairman, and then I went to the man giving the first year course in psychiatry at Tufts. And his was very much of a psychoanalytic approach. He basically told me that there was no research in psychiatry at Tufts. At the time, this is 1954, 55. And he said that he did give a course in the psychoanalytic interpretation of the great books. Well, I felt that I'd really had that as a liberal arts major at Yale, and understood that, but I was really interested in research. He sent me over to see the chairman of the physiology department. As I said, they had a small department. The chairman was interested, not only the chairman, but people in his department were interested in the biochemical aspects of exercise physiology and so forth. But they said there was this new guy who had come to the neurology department who was just far enough out to be interested in some of the things I was talking about, like behavior, the biologic basis of behavior, instinctive behavior, and so forth. So they sent me over to see this Dr. C. Wesley Watson. And Dr. Watson was an interesting character. I studied with him as a student, and eventually I became Sherlock Holmes, right, to add a little wit here. But he was interested in studying epilepsy. And that's basically how I got interested in studying epilepsy. And he was interested in studying instinctive behavior and reflex basis of behavior, and that's basically how I began to do neurosciences. I worked with him when I was a medical student during the summers, did a little work during the years, but we didn't have a lot of electives in those days. There were no electives in the first, second, or third year. The fourth year was essentially a rotating internship. And if you didn't take any vacation time, you had 3 months of elective. So that it did not allow much time for, research or things like that. But I managed to do some research with him, and we presented several papers based on that research, so forth. And basically, most of my career was related to research in epilepsy and teaching of neurosciences, teaching of neurology.
Can you talk a little bit about how the science of neurology has evolved? It sounds like you were there right as it was starting to be practiced by physicians. How has that changed over years?
It's changed for the better. It's changed for the worse. Basically, when I entered my training in neurology in 1958, I had decided to go in neurology even though I was a medical intern at Yale. There were probably 400 or 500 board-certified neurologists in this country. I would say we probably have close to 10,000 board-certified neurologists now. We had many more neurosurgeons in that era than we had neurologists. So in many of the smaller towns and cities, neurology was done by the neurosurgeons. Worcester, which was, is at the present time the second largest city in New England, had no neurologist until approximately 1964 or 1965. Herb Rubin came out here. He had been from Worcester. He was the brother of one of the psychiatrists here, Bert Gutterman, and he came, but then he had to go into the Army. And then there was no neurologist again until 1968. At the same time, there were lots of neurologists in Boston. Most of the neurologists in those early years were affiliated with universities. Many of them did a great deal of teaching. What's changed is the large number of neurologists who are in private practice and so forth. What's changed is the fact that even those who are in the universities are doing more and more practice. Either they're doing full-time research or they're doing essentially full-time practice. Teaching, it has become more and more difficult to get people to reserve time for teaching. Neurology in those years, the early years, was mainly a consultation specialty because there were so few neurologists. It then evolved into situations where you had inpatient neurology services being set up, and you had neurologists then being the patients responsible for, neurologists being responsible for patients admitted to the hospital. The HMOs have shifted that situation to some extent again. In that era, we didn't have Medicare, we didn't have HMOs, people got admitted to the hospital. Many patients that today we would work up as outpatients were admitted to the hospital. Why were they admitted to the hospital? Well, because their insurance, contrary to what goes on today, their insurance would only pay their expenses if they were in the hospital. It's sort of like the movie that Woody Allen made called Sleeper, in which he wakes up having been cryoed after 200 years, and he finds that all the things that were good for you are now, that were believed to be good for you, are now bad for you, and all the things that were believed to be bad for you are now good for you. So almost everything was done on an inpatient basis. Certainly we saw outpatients, and we saw a significant number of outpatients. But when I reflect back, I would say that at least 70% of the patients that we saw in the hospital, we would now see as outpatients.
Is that a positive change, do you think?
Some of it's a positive change in the sense that you don't need to admit a patient with a dizzy spell or a headache into the hospital to evaluate them. You don't need to admit a patient with multiple sclerosis or amyotrophic lateral sclerosis into the hospital to determine what's going on with them. A good part of that is not simply a reflection of managed care, but a reflection also of the evolution of the diagnostic studies. Okay, we have CAT scans, we have MRIs. Those all can be done on an outpatient basis. Those studies have significantly reduced, almost eliminated studies such as the pneumoencephalogram. We never do a pneumoencephalogram anymore. We almost never do a myelogram anymore. We do very many fewer arteriograms because we have things called MRA, so forth, magnetic resonance angiography. So a lot of the things we did were invasive studies for which we admitted patients to the hospital. Even if we were going to do those invasive studies, we'd do them on a day surgery basis now. The other aspect was we had some tests like electroencephalograms, which we could do, but the electroencephalogram only gave us an indirect measure of what was going on. It didn't give us a picture, a structural picture. And we do many fewer electroencephalograms now. When I was a resident in New England Medical Center, they probably did 3,000 EEGs a year. I doubt that they do 1,000 or 1,200, 1,500 now. When I first came out to St. Vincent in 1976, and this was before we had any CAT scan or MRI in Worcester, we did about almost 2,000 EEGs. They're under 1,000 now. Okay? So those are the things that have changed. The reimbursement for patients you saw, that's changed also. Almost no one pays cash anymore. In that era, we saw patients and they paid, if they could, they paid for the service. If they didn't pay for the service, well, all right, they didn't pay for the service, But third-party billing, permission from third parties, there was none of that. It was simpler. It was a simpler time.
How do you think third-party billing has affected the relationship between physician and patient?
That's a difficult question. We were, in that era, patients often wanted to be admitted to the hospital if they had insurance, if they had Blue Cross Blue Shield, which was the dominant form of insurance, they wanted to be admitted to the hospital so they wouldn't have to pay the outpatient expenses. And maybe we went along with that. Sometimes we didn't, depending on what the total, situation was, the total gestalt. Now, patients may want to be admitted to the hospital, but there's no way that their insurer is going to pay for it. It's quite the opposite situation. There are so many people looking over your shoulder that does influence how you relate to patients. Patients say, well, I really thought I ought to have an MRI, but the doctor just couldn't arrange that. Well, he couldn't arrange it because the insurer said there's no way that an MRI should be done. Or we have practice guidelines, and the practice guidelines say there's no need to do an MRI. And patients sometimes don't understand that MRIs do not cure disease directly. They are often preoperative tests, and one sometimes dealing with a patient who who doesn't want to have the surgery to begin with. So there are a lot more controls on what doctors do. There are a lot more, and the relationship is not simply influenced by the insurance. We live in an era of malpractice cases, etc. There were many fewer in that era. Clinical research was a lot different as well. We didn't have human investigation committees. We tried things out. Now we wouldn't try them out. We more readily were able to do research, clinical research. We were more readily able to do animal research. There are so many controls imposed. There's so many problems. Much of my work was done in primates. Nobody is very likely to do primate research today. Number one, you've got to go through so many committees. Number two, there are people out there who may try to come into your lab. You've got to have security, et cetera. And number three, the cost of doing it have gone up tremendously. A good deal of work is done on the mouse and the rat, and it has limited applicability to man, okay, to humans, not just man, women as well, okay? And so that's a problem in terms of research. The funding of research has changed tremendously, okay? When I was a student, I did research. It was piggybacked on my mentor's research grant. Or I did much of the work myself. I think my initial laboratory project was to study the development of neurological symptoms in cats with uremia. Okay, so I devised a method of producing uremia. What did I do? I would remove one kidney and radiate the other kidney. How did I radiate the other kidney? I spoke to one of the radiologists, and in the evening, he took me down to the area where they did radiation, and we radiated the kidney. Simple, no problem. I did laboratory studies, calciums, phosphorus, BUNs, to determine the biochemistry of their uremia, et cetera. Who did the studies? I did the studies. When did I do the studies? I did them in the evening. Where did I do them? I simply bought some glassware, and the director of the clinical chemistry lab said, fine, go ahead and do it. Things were simple in those days. We were in a growth era. Research was supported, and it was not very costly, okay? And without a great deal of regulation. I did some work as a fellow. Where did the money come from? I probably did 1 or 2 animals a day. Where did the money come from for that? Oh, it was piggybacked on a grant. A grant that probably had very little to do with the actual research, but it was surplus funding, et cetera. There was a lot of fat in the system in those days, let's put it that way. I went into the Army after my fellowship. I had 2 years. We had compulsory service in those years. I functioned as a neurologist in the Army, but while I was away, my mentor put in a grant request, basically saying, here's what we're going to study. I had actually studied that during my fellowship, but when I came out, there was the funding. There was a laboratory waiting, and I went right back into working in the lab. I did a lot of other things as well, but I knew there were funds. I sat down as soon as I got back out of the Army, and I wrote a research grant and knew that I would be funded with my own research grant. And that went on. The ease of getting research funds went on into the early 70s, and then the crunch began to come because we were dealing with the fact that there was not an unlimited amount of money. We got into the problems of the costs of the war in Vietnam, the fact that under Johnson, they did not wish that to interfere with the Great Society program, et cetera. So there were cash flow problems in terms of the government. And the philosophy changed. So now it became more and more difficult to continue getting funding. The total approach to people going into academic medicine was a lot different. When I went into the Army for 2 years, 1963 to 1965. I came out of the Army, and I joined the faculty at Tufts. What was I to do? I was to spend a third of my time in research, theoretically, a third of my time involved in setting up a neuroscience teaching course, and a third of my time doing clinical work. And for that, I think I received a magnificent salary of $15,000. $5,000 came from the school to basically set up and teach the neuroscience course. There was only one other person involved in teaching neurosciences at the time. A third from what they called a GRS grant to the hospital that provided for some funds for my time for research. The funding, as I explained, came from other sources. And a third came from the hospital for my clinical activities. Well, my clinical activities more than brought in that 1/3 of salary because I did many things. I went through an era then, and many people did, when you were supposed to be a triple or quadruple threat. And I went through that and did that and went up through the academic ranks to a professor, you know. But as the crunches set in, it became more and more difficult to do that, okay? So you have, there are very few people now who are going to do all of those things. It becomes very difficult. Less and less income is generated from practice. People run faster and faster to remain in the same place in terms of generating practice income. And I'm not talking about people in private practice. I'm talking about people at Tufts or here who are on the full-time staff here. So the clinical departments have to see more and more patients to make the same amount of income. Okay.
Are you finding that less and less physicians are going into academic medicine nowadays?
Well, departments have grown, which would suggest that the total numbers have increased. I think that what's changed is that people have salary expectations that we never had, okay? At a time when I began at $15,000 a year, I would say that in practice you might have started at $40,000 a year. Now, people beginning in an academic clinical department would expect to receive about as much or close to as much as they would make in private practice their first several years. Eventually, the people in practice are probably going to make more, although that's not if you get to be a professor or get to be a chairman, you're going to make as much or more than most people can generate in practice. But there are more, and we have much larger departments than we had. Here, I came out here in 1976, essentially to set up a department at St. Vincent. And I was, for a year and a half, the acting chairman here at the medical school. Initially, the medical school, when it was set up as a department, initially it was a division of medicine. That was a temporary maneuver. And that ended in 1977. But initially, it was to have something like 6 people. Well, I would tell you that it now has, on a full-time basis, something like 16 or 17 people. A few of them are doing majority of time in research. The majority, however, are doing clinical work. So departments have grown larger. The wherewithal for supporting them becomes harder and harder because reimbursements, clinical reimbursements, have gone down. The amount of money one would receive from doing many of the ancillary studies has decreased because those ancillary studies aren't done, like EEG, EMG, and so forth. Imaging studies have replaced those, but the neurology department, the clinical department, doesn't see that money. That clinical department doesn't see the money. That goes into radiology. Things have changed. And the idea that you could teach an entire neuroscience course, be a very active clinician, read 1,000, 1,500 EEGs a year, carry out research that would be funded by the NIH, to do all of that becomes almost impossible today. But I'm happy I did my research, and it was quite significant, in a golden era. I organized a neuroscience course and was involved in it in a golden era, wrote a textbook. Golden era when publishers were looking for books and they were willing to fund such endeavors. Those are problems. There are few and few publishers now. They've all gotten merged into gigantic, combinations.
You mentioned there's much more control now in medicine. How has that affected the way you feel the public views physicians, say from when the time you first started practicing?
I would say that the public's image of the physician has significantly decreased. There was a time when people held their doctors on pedestals. Most patients did. They probably would go along with whatever the doctor had to say. Were there patients who would bounce around from one specialist to another? Certainly. HMOs have decreased some of that bouncing about, have put controls on that, and that is a source of patient discontent. There's an active movement that wants free access to specialists. And there's no doubt that HMOs have restricted access to specialists and restricted unlimited access to specialists. Although the HMOs have had to adapt to that, and there are bills in Congress pending that will increase access to specialists. There are all sorts of horror stories you can see periodically on 60 Minutes or 20/20 about patients who should have been seen by a specialist a lot earlier in their disease course, and when they finally saw the specialist, it was, quote, too late, end of quote, So, other questions that you might have?
What do you think the relationship between physician researchers and practicing clinicians has been, and has that changed over the years?
There was a time, I think, that many referring doctors were quite willing to have their patients included in research protocols. There were centers and doctors. There was a referring group of doctors who would send their patients. I think that the growth of HMOs has put certain limits on clinical research.
I asked because it sounds like when you started, somebody could be both a clinician and a researcher, and now
that's correct.
Much harder.
Well, they can be a clinical researcher. I was carrying out basic science research. if you're going to be studying the role of the corpus callosum in seizure transmission, what large areas of cortex are capable of, that's more basic science type research. You could do that. Now the competition for funds for basic science research is so limited that, I mean, yeah, there are more and more funds, but there are a lot more neuroscience. That's another change. There are thousands and thousands of PhDs in neurosciences who want to be funded. Many of them have gone through postdoc position after postdoc position, and there are no positions available for them. So that there are a lot. What has seen is there are fewer and fewer MDs getting research grants from the National Institutes of Neurological Disease. There are a limited number of MD PhDs who are still getting basic science grants, but the number of MDs who can only put part-time work into it, that's essentially disappeared. That is a significant cause of concern for many of the neurological societies. The fact that there are fewer and fewer MD neurology types being funded in terms of research. And then you asked a question a few minutes ago about people going into research, going into faculty positions, etc. Let me just go over a few things that may be relevant to that. I graduated from medical school in 1958. I had, from Yale, I'd had some scholarships, I'd had some loans. I owed Yale University all of $400, which I repaid in part during my internship when I was receiving only $25 a month as an intern at Yale, and then paid it back when I was a first-year resident. I could have the luxury of spending, after my first year of neurology residency, going off to New York and spending a year doing neuropathology and spending some time doing neurophysiology. I could have the luxury, when I was the chief resident, of spending half my time in the lab. They had a lab available, and I had learned some things in New York about neurophysiology. And then the luxury of spending a year's fellowship. Okay, could go into the Army for a couple of years, where actually the salary was actually a little higher than what I received as a fellow and resident. But then I came back, and I came back to a faculty in which I made a certain amount per year, $15,000, which was not considered a very great salary. But my expectations were not great. My wife was also a physician. She, with much more training and experience, was paid only $12,000 a year. She came to the New England Medical Center as well. She actually received less than the chief surgical resident. And it was very clear why she received less. She was a woman. She was a woman in a surgical specialty who should have received, you know, a lot more, but she didn't. She even was told by her chairman at one time, and I was very friendly with the chairman, and she was also, but he said, you know, he said to her, she never quibbled over salary, but he said, you know, he said, you and your husband together are making about as much as I make. Now that was a totally inappropriate, we would consider that a totally inappropriate comment today, but it was not considered inappropriate at that time. But the fact is that neither of us had any significant debts. Did we own a house initially? No, we didn't own a house initially. We bought a house, probably about 5 years after we came back to Boston. Now, I think the expectation of interns and residents and young faculty is, well, gee, I'm a resident, I'll buy a house, you know? I think their expectation as to what their salary level should be. I mean, as I said, as an intern, $25 a month. I think we probably pay interns $30,000, $35,000. You people may know a little better than I do. Right. And as a resident, actually, I was on an NIH clinical traineeship in those years, the first year. I think I got $3,600 a year, but we were told to be very quiet about that because the medical residents were receiving less. And as a fellow, I probably reached a level of $6,000 a year. I was quite happy. My expectations were less. People have much different expectations. They also have significant debts. And I think having significant debts from college and medical school significantly influences what you do. You don't have the luxury of saying, well, you know, I think I'd like to spend a fellowship year in New York. I think I'd like to work with Dr. So-and-so. So I think from a financial standpoint, people have many more debts. They also have much higher expectations of what their standard of living is going to be immediately. Which is not to say, you know, we didn't live well. We would go off to Europe in the summer for a month or whatever, but didn't. Well, my wife had relatives in Europe, so it didn't cost us very much. But I mean, we had different expectations, and we could, you know, live within our means. And I think a lot of people today don't live within their means, but that's, you know, just my conservative fiscal policy, although I am politically a liberal.
Yeah, that is something that we're interested in, is how the debt that people coming out of medical school have influences what they go into.
Yeah, that's hard to say because certainly does that influence people going into subspecialty areas such as ophthalmology or radiology, or in the invasive medical specialties such as cardiology and gastroenterology? Oh, I'm certain it does to some extent. On the other hand, I also would suspect that people are interested in doing those things. It's always hard to, you know, work all that out. I would say that the true test would be to say, fine, we're going to pay all doctors the same salary for the same hour of work. And then we would see whether people are really interested in X, Y, and Z. However, I would be denounced as a socialist or worse by my medical colleagues were I to propose that. I have proposed that. It doesn't go over very well. Right. At Fallon Clinic. Now, at Fallon Clinic, many of the subspecialists in the non-procedure areas of medicine, whether it be infectious disease, neurology, endocrinology, rheumatology, were paid basically on the same salary scale as general internists and family practice physicians, or I believe pediatricians. However, we continued to pay gastroenterologists and cardiologists at a higher rate. The person who instituted the idea that all these specialties would receive, subspecialties would receive the same reimbursement was Dr. Yud when he was the VP, the medical director at Fallon. He was a rheumatologist, and we went along with it because even though we had spent longer periods in training than people in general internal medicine today is an internship and 2 years of residency. Many of us, as I've indicated, had not only an internship and 2 or 3 years of residency, but several years of fellowship as well. We went along with it with the idea that, you know, in a sense, the differential we were receiving was not that much to begin with, and it was fair. People were expected to put in a goodly number of hours, and why shouldn't people be reimbursed for the time they put in? As far as I'm concerned, they should have extended to the cardiologists and gastroenterologists as well. Everybody should have been receiving the same salary. In a time, you see, if there was a shortage of cardiologists, it would be difficult to do that. If there were no shortage, and as the rate they're turning out subspecialists, that we may reach that point where there's no shortage, and then I think you'll see groups that do that. There have been groups that have offered a premium for people going into primary care as opposed to their specialists. Specialists were viewed as expensive. In actuality, that view has changed. Specialists are not that expensive if they deliver the first time around your correct diagnosis and decrease the amount of extraneous ancillary work that's done. Okay? So those views, the interface of primary care and specialization and the reimbursements for that, those have shifted over the years. And at one point, we had a shortage of primary care physicians. It's not clear that we necessarily have a shortage of primary care physicians now, particularly when you have a significant increase in the number of nurse practitioners. Right. Do we have a shortage of neurologists? No, we don't have a shortage of neurologists, but we will down the road. We trained a large number of neurologists, an increasing number, and then as the reimbursements went down and so forth, and for various reasons, people began not to go into neurology and some of the other cognitive specialties. The large number of people we trained, they should be retiring in 15 to 20 years. And we've had a marked decrease in the number of particularly American graduates going into neurology. As recently as 2 or 3 years ago, there were something like 150 training programs, each of which offered 3 or 4 entry positions, but there were only 150 or 155 American graduates going into neurology. And they didn't all go 2 by 2 like Noah's Ark. You know what I mean? So we are going to, our system is one in which we have marked fluctuations in manpower and where the manpower goes. When I was a young faculty person at Tufts in the late 1960s, the government was encouraging medical schools to expand the number of students they were taking. Tufts went from 115, and with government subsidies and increasing tuition, went to now I think they have about 170 entry students per year, at a time when they also had a decrease in their clinical facilities, significant decrease in their clinical facilities. But they're so dependent on the tuition that's generated that they've never cut back. We're producing probably too many physicians, and but the schools will not cut back. Some of them have cut, and but the government stimulated this by offering these incentives and then eliminated the incentives.
Can you talk a little bit about your involvement in medicine in Worcester?
Okay. What aspects do you have in mind?
Well, you said you're involved with the Fallon Clinic?
That's right. I have been. And at St. Vincent Hospital. I came out to, the reason I came to Worcester was to be the chairman at St. Vincent and to establish a neurology program that is a teaching program at St. Vincent, and to establish a residency program with the medical school. I've been involved with the Worcester District Medical Society. I've been involved with physicians in Worcester, but I've always been, you know, I've been a full-time physician, and there's always been a tension, if you will, between the full-time physicians and the physicians in practice. A good deal that I suspect changed over the years, but it changed in part because we had fewer and fewer practicing physicians in Worcester. When I first came to Worcester, most physicians went to several hospitals. They were not polarized. And there were a number of people in practice who would send patients to me for consultation. I must say there were very few neurologists when I first came in 1976. There was, let's see, Dr. Rubin, Dr. Bazemore, Dr. Birbiglia, and I came as the full-time chief at St. Vincent with the idea that we would recruit additional neurologists. And we did. Initially, I not only took care of most of the neurology at St. Vincent, although there was an active practice neurologist, Dr. Birbiglia, and then he had an associate, but there were no neurologists. There were a limited number of neurologists able to service Worcester City Hospital, so they called me, and I would go over to Worcester City to see patients. I occasionally would go over to Memorial to see patients, a second opinion. And when I first came, I took care of all the neurology here at the medical school as well, until they recruited a full-time chief, Dr. Drachman, who came late in 1977. Now we have large numbers of neurologists, and things are very polarized. The neurologists at Fallon Clinic see only basically the patients from Fallon Clinic. They don't see patients from doctors at Memorial. They don't see patients from doctors at the university, because in each of those areas, the institutions have developed their own cadre, and things are very polarized. We're basically down to two institutions in town, right? The Memorial and UMass are now one institution. St. Vincent, Fallon Clinic, basically another institution, although that's a variable situation, right? When I first came, there were other hospitals: Worcester City, Doctors Hospital, Fairlawn, Holden, Hahnemann. All of those were separate institutions.
Has the consolidation been a positive effect on medicine?
Well, that's a tricky question. There are doctors who will tell you that it's not been a positive aspect. You have to balance, in the sense that these hospitals served, particular groups of doctors, particular communities. Some of them, Hahnemann was viewed as less critical care, better, nursing. The nurses rubbed your back, gave you a bath, etc. Whereas at St. Vincent and UMass, those were very critical care-oriented institutions. And that was a complaint I heard before I even came out to Worcester. One of my friends that I knew had been from Worcester. Her mother still lived in Worcester. Said the mother used to go to St. Vincent. This is in the early 70s, but didn't like to go to St. Vincent anymore because the nurses were so busy they didn't have time to do those little things that she could get by going to Hahnemann. The same was true, of course, of people who went to the Holden Hospital or people who went to Fairlawn. There was a particular cadre of doctors who took their patients there. Now, of course, did Worcester have too many hospital beds? Certainly, they had too many hospital beds, particularly in view of what was going to occur, this impact of HMOs and of studies that you could do as an outpatient, so that the hospitals had to decrease and they had to consolidate, and the marginal players were eliminated. So that in this era you can only have hospitals that basically are strong from a financial standpoint, strong from a medical standpoint. The marginal hospitals, I realize the doctors who were associated with those hospitals and the people who went to those hospitals wouldn't call them marginal, but okay. But let's be realistic.
When you came to us from Boston, are there any major differences between how things were medically run out here than?
Yeah, I came from a situation where at the New England Medical Center where everybody was full-time. And now St. Vincent had a full-time staff, but the full-time staff didn't run the hospital and didn't control the hospital. Let's say the full-time staff were the chiefs of service, the directors of the labs, et cetera, the full-time directors of the lab, but they didn't run the hospital. And there were fewer controls on what was done by individual physicians. You had many, many individual physicians whose philosophy of what they thought the hospital should be was contrary to what the chiefs of service thought the hospital should be, contrary to what the administration was attempting to do. That was not the case at a full-time hospital in Boston. I mean, if you were at the New England Medical Center and you said, I don't think this should be a teaching institution. I don't think that we should develop a residency program. I don't think that patients should be covered by residents. You weren't there any longer, you know what I mean? Whereas here, well, that was a different situation. There were people who were actively opposed to institutions being teaching institutions, who were actively opposed to having medical students and residents involved in the care of patients. Okay? So it was an entirely different situation. I think a good deal of that has gone by the wayside now. We have only basically two and a half institutions, okay? Two, quasi three, all right? And I don't think those are issues any longer, right? But they were at the time. And a department wants to recruit another full-time person, you don't have the entire staff marshaled in opposition, et cetera, et cetera. These are decisions that are made by administration based on clinical needs and financial wherewithal. It doesn't, the part-time attending staff is no longer involved in those types of decisions. You see, I think that these were issues that went on 20 years ago, et cetera. They're no longer issues. There's no doubt that, you know, these are major teaching hospitals and so on. But in that era, there were serious questions about what people should do at St. Vincent Memorial, so on.
To talk about politics a little bit, do you think that physicians do or should have a role in community politics or even state or national politics?
I think physicians should be actively involved. I think it's a question of how many have time to do that. I see, I served for a number of years on the council, and then it became the House of Delegates of the Mass Medical Society, and you would see there people who were essentially politicians, but they were carrying it out through the Mass Medical Society. How many of them became involved in running for the state legislature, running for town meeting? In Brookline we have a representative town meeting. Not too many. I don't know that they had the time or that they wished to really involve themselves in politics at that level. Did some of their wives become involved? Yes, some of their wives became involved.
How do you feel that physicians can have a say in the healthcare system, whether it's government or HMOs or anything?
Well, HMOs, I think, is another issue. As you probably are aware, the Fallon Community Health Plan was set up by Fallon Clinic, by the physicians at Fallon Clinic, and the boards of those two organizations did overlap for a long time, and there was a very close working relationship. Fallon Community Health Plan has now evolved into the more traditional nonprofit insurer HMO sort of thing, and there's probably less of the degree of control by Fallon Clinic than there, certainly there's a lot less than there went on before. Fallon Community Health Plan has had to expand, so they've gotten away from the full-time model that they began with back in the 1977 or so. At the beginning, it was only their full-time staff, except in those areas they didn't have specialists. They recruited people to do the specialty work. For example, I was the first neurologist for the Fallon Community Health Plan, even though I was not a full-time Fallon physician, but I did most of the neurology for Fallon at the time. The Central Mass Healthcare also evolved from the physicians in Central Massachusetts, but then it became a business and they lost control of it, and it became subject to leadership that was less than conducive to effective, efficient control of the finances, et cetera, i.e. there were probably some sweetheart deals and some other unsavory aspects that the Attorney General eventually looked into, and as you probably are aware, Central Mass Healthcare was then sold to another insurer, which then was sold to another insurer, et cetera. The same is true of Blue Cross Blue Shield. You probably are not aware of the fact that both Blue Cross and Blue Shield were set up in the 1930s at the behest of physicians. Blue Shield in particular set up by the surgeons so that patients could pay their surgical bills. Initially, it did not pay for medical care, or it had paid only for a limited number of diagnostic studies. The radiologists were early involved in it, but a lot of other diagnostic studies were not paid for. Over the years, it expanded, and eventually the physicians no longer had any control over what was going on, even with Blue Shield, and then they were merged and they had even less control. So that unless you have physicians who are particularly interested in those areas, and even there it becomes a problem. When physicians have become involved with these organizations as, quote, administrators, whether it's with insurance organizations or with hospitals as administrators, they become administrators. They tend to lose, well, they talk the game. Again, some people looking at this might not find this particularly enchanting. They no longer are friendly, overly friendly to the physician's view, okay? So that's a problem. They become administrators, and they take on all the characteristics of administrators, and fewer of the characteristics of what does the practicing physician feel about this. In terms of politics, what can physicians do to be involved in politics? Well, they should know who the representatives are, both in Congress and in the local level. A place like Worcester, that's probably not too difficult. And the representatives from Worcester have been particularly sensitive to the views of the physicians regarding health care. Harriet Chandler, in particular, has been particularly friendly and open to the views of physicians. A lot of doctors don't want to have anything to do with politics. Okay?
Just to wrap up, can you tell us, would you advise people to go into medicine today? And for young doctors, what advice would you have for them?
Right. Okay. I certainly would advise people to go into medicine. I think there are still many, many challenges. I think one has to look beyond the problems, the various hassles, the reimbursement aspects, etc. And I think you have to look at the many opportunities that are still available. Medicine's one of the few areas where you can go into the area and you could do multiple possible things. Okay? I have only one child, a daughter, and she has gone into medicine without my wife or I really saying, well, we think you should go into medicine. We didn't encourage her to go into medicine, but she did go into medicine. And she has tried various, she's been able to do various things in medicine. It's probably going to do additional other things because I think many people have that pluripotential. Now, that's not true for all people to go into medicine. I think some become locked into one area and lose their capabilities of doing other areas. What advice do I have? Number one, avoid debts so that you can keep your options open. Number two, don't go into an area just because you think it's going to give you a highly remunerative lifestyle. You should be interested. There should be a clear-cut reason why you go into an area. You should have some interest in, you should really have a major interest and commitment to that area. You may not end up doing in that area what you necessarily thought you were going to do. After all, I've gone through various careers. I've been a neuroscientist, I've been a clinical neurologist, I've been a clinical neurophysiologist, I've been an organizer of teaching, I've been an administrator, and now that I've retired, I'm back as a teacher of neurology and neurosciences, which I enjoy doing, and I have the time to do it and the luxury of doing it. I'm independent, I can do that. So, on the other hand, I see people who many physicians I see lock themselves into practice. That's all they do. They have very few interests outside of medicine. And so they continue on practicing, probably long after they're still current, they're still on their toes. You understand what I mean? Because they don't have other interests and there's no other alternative to them. I think the other thing I would advise people to do, there are things in the world and in life other than medicine. It is not necessary to go directly from college to medical school. You can do other things. I went directly from college to medical school, but I, in my education, had other interests. Right. The relationship of child training and personality development probably has very little to do with neurology, and classics and archaeology probably have very little to do with neurology. So I think that you should have a broad background, you should be broadly educated. People shouldn't simply take, quote, pre-medical courses that are going to duplicate what they take in medical school. I think it's possible to have the minimum number of pre-medical courses and to do well in medical school and in medicine. I mean, that was my case, that was my daughter's case. She never deigned to take a science course as a Yale undergraduate until she was at the end of her third year, because why would she, quote, waste any courses on pre-medical courses when there were so many other interesting things to do? And she had a career before she went to medical school in which she worked as a reporter and did journalism, and that was of value when she did go to medical school. So I think that you should be broadly educated. I think you should do those things that you enjoy doing. Don't do them simply because you think the remuneration is going to be high, because it may turn out, like Woody Allen said in The Sleeper, the things that are highly reimbursed one day may not be reimbursed the other. So you better end up doing those things you enjoy doing. And you ought to keep your mind open and think about why things happen, you know? I mean, think about the research possibilities as well, and avoid debt. But that may be impossible to do. The cost of college education, the cost of medical school education, of course not here in this school, but in most schools. Tufts, for example, my tuition when I entered was $600 a year. The cost of living in Boston was very inexpensive at the time. Now the tuition at Tufts is probably $32,000 a year, and the cost of living in Boston is very high. Has the cost of living gone up as much as that tuition has gone up? No. So that's a serious problem for people who want to go into medicine. Good.
Our taping.